After learning about how to diagnose and treat VAP, a very important factor which we are going to discuss now is, can we really prevent VAP-associated pneumonia? VAP, that is ventilator-associated pneumonia. Now the definition and the early and late onset VAP has already been explained in great details. Now the breakdown of hospital-acquired pneumonia, if you look at it, 37% of VAP occurs in ICU, and of this 86% occurs in patients who are ventilated. The impact of VAP is numerous. It increases the duration of ventilation, increases the ICU stay, and also increases the mortality. Hence, it is very important to analyze whether we can prevent it. There are various guidelines given by various societies world over for prevention of VAP. A patient in ICU, or for that matter in hospital, is at risk of acquiring respiratory infection through various sources. And if the patient is in ICU, endotracheal tube is another important conduit which predisposes a patient to ventilator-associated pneumonia. Now, there was a paper published by Morrow and Koleff in Critical Care Medicine 2010 addressing these issues. The measures for VAP prevention were divided into non-pharmacological and pharmacological. The non-pharmacological measures basically deal with endotracheal tube, ventilator circuit, heat-moisture exchange filter, patient position, type of beds, and the pharmacological strategies deal with use of antibiotic, oral, IV, or local antibiotics, and use of antiseptics. So thus, we have more than 28 potentially effective measures for VAP prevention. Now let's see what is the evidence. As I told you, endotracheal tube is an important conduit which contributes to a large amount of ventilator-associated pneumonia. As shown by Holzapfel in 1993, patients who are orotracheally intubated are at lower risk. They have more infection-free period compared to those patients who are intubated nasotracheally. There are other studies which support that patients who got sinusitis are at increased risk of acquiring nosocomial pneumonia. So if a patient is nasotracheally intubated, he is at higher risk to acquire sinusitis, and these sinusitis predisposes a patient to nosocomial pneumonia or ventilator-associated pneumonia. A patient. Now the endotracheal tube cuff should form a firm seal so that the secretions which are there above the cuff should not leak down, or the patient should not have aspiration, which results in ventilator-associated pneumonia. A nice diagram shown by Lucangelo, the study which he did, he used two types of cuff and showed that if there was an adequate seal, the dye did not leak down compared to if there was no adequate seal. So some studies have suggested that the ET cuff tube pressure should be maintained between 20 to 30 centimeters of water to have adequate seal of the endotracheal tube cuff. Later on, Pollard has shown that polyurethane endotracheal tube was protective for early onset VAP. It prevented the aspiration of secretions below the cuff. Laurent further showed that polyurethane tube with subglottic suction significantly reduced both early and late onset VAP. As shown in this diagram, patients who were using polyurethane cuff tube had a lower incidence of VAP compared to those who were not. Now as we know, subglottic secretion drainage is one of the important factors for preventing VAP, and there are specially designed endotracheal tube available with which you can have a continuous aspiration of subglottic secretions which occurs above the cuff. The suction can be either manually or through automatic means. And Koleff showed that those patients who had continuous aspiration of subglottic secretion had higher probability of remaining without VAP compared to those who did not have continuous aspiration of subglottic secretion. A meta-analysis by Desfoulian again was in favor of using subglottic secretion drainage to reduce the risk of VAP. So to summarize, subglottic secretion drainage prevents early onset VAP. It reduces and prolongs VAP in cardiac patients especially, and ETT with polyurethane cuff and subglottic secretion drainage significantly reduced VAP and delayed the time to occurrence of VAP. Then Rello showed that if you use a silver-coated endotracheal tube, it reduces the burden of bacterial colonization And Kolev subsequently, in his nascent trial, it showed that if you use a silver-coated ETT, it significantly reduced the incidence of VAP and delayed time to VAP occurrence. As shown in this study, these were the patients who had a silver-coated ET tube versus those without, and there was a significant reduction in the VAP rate between the two groups. Same thing by a different curve. Now, open versus closed suction system. There's always a debate on this. What do the studies show? A meta-analysis by Weinberg showed that there's no difference in whether you use a closed suction or an open suction for ventilated patients. Again, there's another meta-analysis by John Gurdon, which again reinforces the same result. Now, John Kolev, he went on to show that if you do not change the closed system catheter daily, like in the earlier study, they were changing it every 48 hourly. But here he went on to show that if you do not change the catheter after 48 hours, still there is no increase in the rate of VAP. At the same time, there is significant reduction in the cost which the patient has to bear. Another study by Laurent reinforced the same observation. This was the group where the endotracheal, this was a closed suction system, where the suction catheter was not changed versus open tracheal suction. There was no difference in the rate of VAP. So, despite no benefit in terms of VAP, there is reduction in cost if the patient is intubated for more than 96 hours, and there is no need to change catheter routinely as per the evidence. So, ultimately it turns out to be much cheaper. Then, how often do we change ventilator circuit? As we know, bacterial colonization in the ventilator circuit plays a role in pathogenesis of VAP. But there are several studies which have shown that there is no difference in incidence of VAP in routine change of ventilator circuit versus no routine change. So, to conclude, there is no need to change ventilator circuit routinely. You should use new circuit for every patient, or if the circuit is visually soiled, you need to change it. As we know, there are two types of humidification system, heated humidification and heat moisture exchange filter. In the meta-analysis by Cola A, it was in favor of using HME filter to reduce the risk of VAP. However, a major impact was with the study of Curtin. If you remove the study from the meta-analysis, there is no significant difference in the rate of VAP between the two humidification systems. There were further two randomized controlled trials which reinforced that there is no significant difference between the two groups, whether you use a heated humidifier or HME filter. Now, Tomacoach showed that you do not need to change HME filter every 24 to 48 hours. It can be used for extended use up to 5 to 7 days without having any impact on increasing the VAP rate. Again, there are several more studies which again say that you can use HME filter for extended period up to 5 to 7 days without having any increased incidence in VAP. So there is no significant difference in the rate of VAP between the two humidification systems, and the recommendation is to change HME filter every 5 to 7 days and not every 24 to 48 hours or as clinically indicated. So HME ultimately turned out to be cost effective. Early extubation, as I told you, endotracheal tube is an important conduit which predisposes the patient to VAP. So we should have fast track weaning, minimize the use of sedation and muscle relaxant, use weaning protocol, and use of non-invasive ventilation for early weaning is suggested. Now, study by Cunot has shown that if you have a nurse-implemented sedation protocol in your ICU, there is a significant reduction in the duration of ventilation, duration of hospital stay, and VAP rate. This was a meta-analysis by Burns, which showed that if you use non-invasive ventilation for weaning a patient, there was significant reduction in the VAP rate. Also, Burns, he earlier published a paper, a meta-analysis, which showed that if you use non-invasive ventilation, of course in the suitable patients, versus invasive ventilation, there is a reduced risk of VAP in these patients. So whenever applicable, NPPV or non-invasive ventilation is better to reduce the risk of VAP compared to mechanical ventilation. Again, a very important issue of staffing. A higher proportion of hour of care provided by registered nurse was associated with lower rate of pneumonia. You may not have 1:1 nursing as was recently published in AJR-CCM. However, the nurse should be trained enough and there should be adequate staff in your ICU that has impact on reducing the VAP rate. Now, another issue of early versus late tracheostomy. A meta-analysis by Griffith showed that there was no difference in the VAP rate in the patients who had early tracheostomy versus late tracheostomy. Another study by Terragani showed that there is no significant difference in the rate of VAP in patients who underwent early tracheostomy versus late tracheostomy. So there is no recommendation for early or late tracheostomy for reducing the incidence of VAP. Semi-recumbent position reduces the frequency and risk of nosocomial pneumonia, especially in patients who receive enteral nutrition. And this was the study by Draculovic, which showed that patients who are in supine position are at higher risk to acquire VAP compared to those who are in semi-recumbent position. However, there is a practical implication to this. A study by Nguyen showed that most of the patients in his ICUs were nursed in position less than 30 degree. Maximum was 29 degree. If the patient is nursed in position less than 30 degree, there was no significant difference in the VAP rate. Subsequently, a novel method of continuous measurement of head of bed elevation was derived in ventilated patients so that you ensure that your patient is nursed between 30 to 45 degree, which is shown to reduce the risk of VAP. This also forms one of the component of the bundles. Now, kinetic beds, there are some studies, if possible and if practical, if you have a setup, you should use, you can use kinetic bed to reduce the incidence of VAP, but there are a lot of cost implications. So not a very important guideline practically. Chest physiotherapy by several studies have shown that there is no impact on risk of VAP. Stress ulcer prophylaxis, another always a debated topic. It's a decision analysis and you have to see if the patient is at low risk of bleeding, avoid stress ulcer prophylaxis. Studies in burn and surgical patients which has shown improvement, but with this increasing resistance, it is advised not to use. Again, this was a meta-analysis which showed that use of antiseptic, 2% chlorhexidine, had reduction in the VAP rate, whereas if you use oral antibiotic, there is no reduction in the VAP rate. Now, gastric versus post-pyloric feeding, again, a lot of discussed topic, but the studies do not show any significant risk in VAP rate between the two routes of feeding. So there is no role for routine post-pyloric feed to reduce VAP rate. A focused education is very important and active implementation, not only having the guidelines in your ICU, but you should also ensure that there is active implementation of your guidelines, which has got significant effect on reducing the VAP rate. Now, there are a number of studies on use of chlorhexidine and VAP, except for this study by Pindia. They have all shown that it is beneficial, it reduces the risk of VAP. In this study by Pindia, the concentration of chlorhexidine which he used was much less. It is advisable to use 2% chlorhexidine as oral application. However, in that study, he had used 1.2%, so maybe that's why the impact was not so evident. So it is advisable to use 2% chlorhexidine as oral application, especially in the cardiac patients, to reduce the risk of VAP. Now, this meta-analysis by Elias was in favor of using probiotic to reduce the risk of VAP. So to summarize, there are various measures to prevent VAP. Some are recommended, some are not, and there are no recommendations on some. Initially, the recommended measures are use of non-invasive ventilation, orotracheal route of intubation, avoid de-intubation, early weaning with protocol in place, silver-coated endotracheal tube, polyurethane ET cuff, use of subglottic secretion drainage, 2% oral chlorhexidine paste, ventilator circuit change only for each patient or if it is visibly soiled, use of closed suction system which change only for a new patient or when there is a malfunction, if there is a leak or the catheter is coated, use of HME filter with no routine change. It needs to be changed every 5 to 7 days unless there is a mechanical problem. Semi-recumbent position, however, ensuring the position between 30 to 45 degree if no contraindication, adequate staffing, use of protocols and bundles, and restricted blood transfusions. The therapies which are not recommended are chest physiotherapy, routine specific stress ulcer or prophylaxis regimen, and topical iseganar. And there are no recommendations on orodigestive decontamination, aerosolized or intravenous antibiotic, and early tracheostomy. Thank you.